Will it be successful? Will IAH be successful long term? We believe it's very likely because all three major sources of health insurance in the country are facing the same problem, and that is a small percentage of beneficiaries driving a huge percentage of the cost. And the insurance systems to date have simply not come up with ways to reduce those costs where they're the highest, and Independence does that. By 2014, we're going to see insurance companies not be able to avoid high-cost beneficiaries as they have in the past under health reform. And there's going to be a requirement for essential benefits to be provided to essentially all private insurance beneficiaries, and that will have to include chronic disease management. We're going to see another 17 million new Medicaid beneficiaries coming on the rolls after 2014. We know we have strong congressional interest in expanding the Independence at Home program beyond the 10,000 beneficiaries that are specified in the demo. And we also know that Independence at Home is the model is very popular with patients, practitioners, and payers, and finally we know it works. And with that, what I'd like to do is pass the microphone on to some of the physicians who actually run these programs and can talk a bit about how it works. Thanks very much.
Thank you, Jim. And now we have Dr. George Taller from the Washington Hospital Center, who will talk about teams, their structure, and other critical success factors. Peter Bowling, Virginia Commonwealth, who will talk about patient selection, and Bruce Kanosian from the University of Pennsylvania, who will talk briefly about financial management. These are just bullet points from experts to help get your thinking going. So the first person to speak is Dr. George Taller. George?
Hello, and welcome. There are two kinds of teams that I think are essential for a successful Independence at Home program. The first one is a clinical team, and the second is an administrative team. And let me speak about each individually. The clinical team is really the essence of Independence at Home, and there's been a lot of talk about physician-led or nurse practitioner-led teams, but not as much about what constitutes the team or what the team is really responsible for. And in thinking of Independence at Home, what we wanted to create was a team that was responsible for providing and coordinating all health care and was accountable for all of the outcomes. And so really is responsible for the clinical stability, for fulfilling the quality indicators, for resource utilization, and therefore for costs, which is very different from the fee-for-service model, where the key issue is efficiency over effectiveness or outcomes. And it really is a matter of how many visits you can pack in. Under Independence at Home, outcome is really the paramount issue. Efficiency is a good thing, but really it's outcome that matters the most. So I think it's a matter of getting the job done right more than fast. And that is a culture change in our clinical teams. But I think it's easier to change the culture of a team than it is to change the culture of an institution or an organization. So this is something that I think most physicians and nurse practitioners actually would look forward to. The second is that if we are going to be responsible for outcomes, what we have found is that medicine or healthcare is really one leg of a three-legged stool. We may write an absolutely perfect medical care plan, but if they can't afford the medication, can't get the medication, aren't able to take the medications, it doesn't really work very well. And so you need to pay attention to many of the social support issues that are critical to implementation of that plan. The third leg of that stool is functional abilities within your environment, what we call housing concerns, which are not necessarily first and foremost on most physician and nurse practitioners' minds. But that is a critical component for success in living in the community. And so part of that team needs to assume case management and social work functions, and you can provide that either by buying those services, in essence hiring those individuals into your practice, which becomes part of the per beneficiary per month expenditures, or you can partner with an organization such as a home health agency that has social workers on staff, or with a social service agency that has social workers who may help you. You're also going to need to have links with other providers in the community, pharmacies, legal services, and transportation, so that the services and medication supplies are all coordinated and come to your patients. The last on this team is the 24/7, and you need to make sure that they're on the same page as the team. Things are not just run by protocol, but take into account the patient's needs. The second part of the team is also very important, and that's the administration. Coding and billing are still important. They constitute the data for HCC scoring, but they also assume many other responsibilities. Gathering, reporting the patient information and quality indicators, marketing, enrolling, and retention of patients, dealing with complaints that are not necessarily a part of our practices now, monitoring resource use, such as visits, admissions, emergency departments. How well are you doing in controlling the costs of the care of your patients? That is paramount for success. And then means of checking the EHR, the monitoring equipment, and then obviously the administration of negotiating partnerships and divvying up the savings, which is a new task that may not necessarily be part of your current structure. And on that, I'll pass the baton to Peter.
Hello, everybody. I am also very pleased to be part of this webinar and to recognize all the people whose hard work have contributed to the advances we made to date. I wanted to make a couple of comments about patient selection and strategies that we have found important based on our experience doing this kind of medical practice in Richmond for about 25 years. We've been hospital supported, which has enabled us to provide some of the dimensions that George has just been talking about, which are not easily affordable in a Medicare fee-for-service world. Particularly when you're choosing patients for IAH, it's the intention of the legislative design, and it's our belief that having really very sick patients in this program is the key to success. And so when you look at an HCC score of 3 or 3.5, such as Gary demonstrated in his initial presentation, these are not typical home health agency patients or even typical house calls patients, but are the sickest of the sick. In our program and in George Toller's program in Washington, we're thinking that perhaps a half or at the most 60 or 65% of our patients might qualify. And the reasoning for picking the sickest patients is those are the ones that tend to go into the hospital to incur the largest amount of costs, and therefore actually have the largest opportunity for improving their outcomes, reducing their hospitalization rates, and systematizing and coordinating their care in ways that are advantageous to the patient, and at the same time allowing your practice to benefit economically from the gain sharing opportunity that's created by the legislation. Important to note that the regulations require you to accept eligible patients who ask to be in your practice center or in your practice area when you look at the FAQs. And one of the things we have not mentioned so far in the webinar is the strong preference from the people at CMS for everybody to look at the FAQs before contacting CMS or preparing their applications, because there's a lot of information on the CMS website. The last thing I want to mention is that when you start into this business with these very sick patients, it's a very different sort of practice than a practice that involves relatively stable or uncomplicated patients, even if they have a number of chronic illnesses. So when you're trying to keep these kind of patients from having to go back to the ER or keep them out of the hospital, you have to be creative and you have to be proactive when they start to have changes in their condition. You have to be on top of the issues within a day if they're an outpatient, and by regulation within 2 days after they've been in the hospital, and similarly if they've been in the emergency room. So it's focused on assuming a very vigilant and engaged practice model that pushes you into the world of the patients and make sure that you're available to them in the event that they're having some destabilization in their chronic illnesses. And with that, I'm going to pass the mic.
Unmuted.
Bruce? Can you get Bruce?
Right. Okay. Am I unmuted? Hello? Unmuted.
Go ahead, Bruce.
All right. I'm muted now? Or not?
Yes.
Okay. Just wanted to make a few comments for those of you who heard the September presentation about HCC scores. The spending target that you get for your practice, the way that the demonstration has been set up, has taken most of the difficult responsibility out of your hands. The target is going to be based on the HCC scores calculated from the diagnoses for, at least for the initial group, for calendar year 2011. So unless you have visits that you haven't submitted bills for already, those codes are already set. In addition, there's going to be a frailty adjuster added to that. And what's not clear is if it's going to be a special frailty adjuster calculated for people who have ADL dependencies that require human assistance, because the frailty adjuster that otherwise is used for MA plans is based on a different measurement, and that is worth probably about 3 or 4% of the score. And then there's going to be a trend factor that's going to be calculated from the relationship of the HCC scores and costs that's going to then project that factor over time. And because there's no updating of the diagnostic scores over the 3 years, which many of you might look at this and say, well, that's a problem. Patients develop new conditions, and that's not being accounted for. That is picked up out of the trend factor. And if CMS and RTI appropriately calculate the trend factor and project that forward, that'll capture the updating of the diagnostic code. So there's not really the pressure to master the HCC coding system. I would say that one of the things that's important is that during the demonstration that you be comprehensive and complete in your diagnostic coding, which means that conditions that you don't typically code for because they didn't really matter, such as someone on chronic oxygen actually getting a code for chronic respiratory failure, are things that will be important going forward. One of the things that's happened in past demonstrations that the contractor has run is they've gone back to check their projected cost estimate or their spending target by using a concurrent HCC model. and that'll be a useful way to check to make sure that the trends that we're being measured against are actually fair and accurate. And that's going to depend on really accurate coding sort of throughout the demonstration. Okay.
Bruce, thanks so much. Is that it for now?
That was it for now.
Okay, thanks so much. All right, we're trying to get back on time here. I'm just going to talk about some of the pending issues. These are things that people have brought up, or that CMS has been asked or is going to be asked, just to let you know very briefly where our thinking is right now. We're going to be asking you later for your thinking. There's been a question of whether the prior hospitalization requirement can be, a high HCC score can be substituted for existing patients, for those of you who have people you've been taking care of for a long time. We have talked about an at-risk care coordination payment. We think the answer is no. That is something we brought up. We've also brought up more frequent payouts from shared savings. We think that is not going to be possible. We think they've gone as far as they believe they can with the 18 months, but we certainly have tried. More pertinent, Stark and anti-kickback law waivers, specifications, or clarifications. Jim Piles has already sent questions in about that. Clarification of ACO and IAH participation. That clarification has already been requested. And lastly, some of the things that Bruce Kanosian has been talking about with regard to HCC methodology are things that we think we need to ask because it's not completely defined in the materials that have been provided so far. So with that, now we are going to get to questions. And what I'm going to suggest here is that I'm going to answer a few of the ones that have been sent in myself, because they are things that are in the next slide, actually, that I'll come to in just a minute. First of all, Linda Colantino, as a project officer, asked me to ask you all, please, to read the specifications and all of the FAQs before asking her questions at CMS, because she's the one who has to answer them. Several of the questions that have been asked here are answered in the FAQs. So just to give you some feel for what's already for what's already there. Can the beneficiaries come from your current census? Absolutely. There are provisions for existing versus new. Another one is how do we determine if our qualified patients meet the admission rehab requirement? You are required under the Q&A to certify that they have met the requirements which are specified in the legislation. Another one is the 10,000 patient limit, a rolling limit or an absolute limit on total unique patients. There is a 10,000 patient cap total in the current demonstration, so that's the answer to that. That's also in the both in the specs and the Q&A. And those are some examples. So it's really important, if you're interested in this demonstration, that you read the materials that have already been provided. But here are some. I'm going to try to sort of send them around that are that may be of interest to everyone. Jim Piles, can a home health agency employ MD, NP, and then apply for IAH using those employed providers, or is that an issue? Jim?
Yes, you can. The FAQs specifically address that. Now, the other question, probably the more pertinent question, is can you do an arrangement like that under state corporate practice of medicine laws? Remember, under those laws, all medical decisions have to remain in the hands exclusively of physicians, or perhaps in some states, nurse practitioners. But yes, you can, and the FAQs state that clearly. And I think we were all very appreciative of CMS for providing that kind of flexibility.
Okay, let me give you one more, and then that's it for you, Jim, in the series. Currently, the home health agencies maintain contracts with PTOT, social work labs, et cetera, for house call practices. Do we need to establish direct contracts with these service providers?
They will probably require, CMS will probably require some evidence that you have those capacities, either in the legal entity that applies or by contract. That's what they're requiring for ACOs. I suspect that we'll see the same thing with independents at home. And one just general comment I would make is, whatever legal issues you come up, you think of later, certainly send them in. But after looking this over in quite some detail, it looks to me like all of the legal issues are, at the very least, addressable. I think CMS has done a very good job of providing a set of instructions and criteria that really are workable.
Good. Okay, Bruce Kanosian, as we expected, there are lots of questions about HCC scores. Let me save poor Bruce from having to answer this one. How can we obtain more information on HCC scoring? Bruce Kanosian did a presentation at the September on-site meeting about IAH, and those slides are on the website. So, and it also, Bruce also refers to sources of further information about HCC scoring generally. And to answer one basic question about that, CMS calculates the HCC scores for one's population. Yes, they do. That is one of the jobs of the contractor. But here's one for you, Bruce. Is the cost savings what is the average HCC score plus frailty factor for a house call patient?
It should be about 3 without the frailty factor. And we don't know how CMS and RTI are going to compute the frailty factor. If they do it for what should be the sort of frail population out in the tail that we represent, and use the human assistance threshold, it should be about 0.25, 0.27, which would mean that you'd expect the average house call patient to have a score of about 3.2, 3.25. We've looked at several batches of Medicare beneficiaries, 2006, 2009, and their average HCC scores are like 2.9, 3.0.
Bruce, the next one. Will the HCC, your favorite question, will the HCC baseline score be the one from last November 2011 used for MA plans or done concurrent with the start of enrollment?
By reading the specifications, it sounded like it was going to be the prior calendar year. So the codes that get submitted by March will be picked up in the sweep, and then that'll represent calendar year 2011, so January through December. And those will be the codes that will be used to generate the HCC scores for people enrolled in 2012.
Okay, a number of questions have to do with the relationship between current billing, current incentive payments that you are receiving, and all of that. And the bottom line answer is that nothing about the current Part B Medicare system for you all changes with this. That means that all of the billing that you currently do for these patients is to continue to be done. If you are eligible for a primary care bonus, you will receive that. And none of that, nothing about the current operation of the Medicare Part B billing system changes because of this demonstration. There are no additional payments except for the shared savings payment, for which one becomes eligible, and therefore it is not set up the same as some of the others where there are interim payments or any other relationship issues that you have to that you have to operate in. Here's one. Here's one that I would also just make render an opinion on. Several people asked about the application itself. It doesn't seem to allow for inclusion of a full-scale amount of evidence documenting your unique contributions or anything like that. I think the answer to that is that if it's not included in the application, it's not required. On the other hand, unless there is some character count or whatever restriction, I haven't looked at it. I'm sure that CMS would appreciate whatever information you have that you can supply. They certainly in my discussions with them, do not want to seem to get in the way of anything. That's about as much time as I think we're going to have with our other limitations for questions. I want to go over what we're going to do with the rest of these, and any else that you have. We will be posting answers to all of the other questions that we've gotten by tomorrow, of the ones that we can answer. We are going to be developing our own list of questions to ask CMS for things that are clearly either not covered by the FAQ so far, or are things that people have major concerns about. We also are going to be posting all of these on our website. So with that, let me just talk then very quickly about where we go from here. Next steps. First of all, for any of you who are interested in this demonstration, please, as I've said before, do read the IAH specs and the FAQs. Also, the AHCP materials, if you've not already read them, we have guidelines which represent the consensus of our expert panels on best clinical and practice management practices for these kinds of programs. We also did a previous webinar in the summer and an on-site meeting in September, both of which are packed with information that may be of interest to those of you who are coming to this fairly newly, or may not have all of the background or been thinking about this as long as some people have. Please go ahead and do use them. With regard to the application deadlines, remember that February 6th is the application deadline for applications under the first of the options, and also LOIs for the consortium applications that might come in by May 4th. The selection, I'm told by Linda Colantino, is going to be 30 days after the applications are submitted. And the start date is supposed to be 90 days after that. So for those of you who are applying on February 6th, you will need to plan to get going by May 1st or thereabouts. And it's important that as you think about which of these plans you are applying for, that you have the start dates in mind, because they really are expecting people to begin submitting information, enrolling patients, and the rest of that by then.
Hey, Connie, I believe, this is Jim, I believe also option 3 has to be in on the February the 6th. That's the national pool.
Yes, I'm sorry. That's right. I left that out, and I'm sorry. Thank you, Jim, for the clarification. But today, we need your help. We need you to let us know the key questions that you believe you need to have answered before you can make an application, and that we perhaps can ask for you that are really important to you. This is, we think, is a wonderful set of specifications, but we're also sure that CMS wants this to be successful, wants there to be a total of 10,000 participants. So we need to know what the key questions are. We also need to know if you're planning to apply, and if not, why not? Just to know, to do kind of a reality check at this point. There will be an evaluation form sent to you. We hope you will fill it out to let us know these things, so that we know your feedback really right away. And the last thing that I want to say in terms of next steps is we are applying for a Learning Collaborative grant to the Retirement Research Foundation, the same one that has supported this webinar and other work that we've done educationally for IAH. To be optimistic, if you're interested in applying and anticipate being approved, we hope that you will put May 2nd in the afternoon on your calendar now, because if all goes well, that will be the kickoff date of our first Learning Collaborative meeting. So with that, we are exactly at 3 o'clock, and I want to say many thanks on behalf of everyone. Many thanks to all of you. And don't forget to give us feedback about this webinar and about what else you need to know and what we need to ask. Thanks so much for coming. Bye-bye.